One, good morning rather. I think it's another pointless debate, but we all are married. We understand the purpose of having pointless debates. So the TNT in rectal cancer is, so what is the point that matters to me? The local recurrence, the distant recurrences, the disease-free survival, the overall survival, the nature of the surgery and the surgical outcomes, the pathological complete response rates, and quality of life of the patient. So, it was the Mercury trial which divided the rectal cancer into the good, the bad, and the ugly. We all understand what is, So we all understand what is the good and the bad and the ugly. So the bad ones are T3A and B. The ugly ones are T3CD and T4. So with this understanding, what we did was, pre-1980s, the local recurrence ranged in the range of 40 to 50%. It was by Dr. Hald et al. Who discovered the TME plane, and he described the TME procedure, and the local recurrences came down to less than 15 to 20%. And then came the radiation. The radiation brought down the rate of local recurrence to around 7 to 10%, and then we developed on that. We did dual agent chemotherapy, and the local recurrence rates are down to 6 to 8% as of now. And this is where we are from the past 20 years. We have dug ourselves deep into a local recurrence rate of 6 to 8%. We have not improved from there. Coming to the distant recurrence of it, distant failure is still the most common site of systemic failure. It is still the most common site of failure in rectal cancer. So if you look at the Adore trial, which Dr. Rajiv also presented, so around 25.6% patients, even in the FOLFOX arm, had a distant failure. And if you give a single agent chemotherapy, the distant failure is somewhere around in the range of 33%. And if you have achieved a PCR, the distant recurrence rates are lesser. So the aim is to control the distant recurrence and achieve more and more PCRs. Coming to the disease-free survival, so majority of the rectal cancers, they have their primary outcome as a disease-free survival and a secondary outcome as an overall survival. In an adjuvant setting, the debate is still going on whether the chemotherapy is of use or not. We are there someday and we are here someday. We give sometime and we do not give sometime. The COSAR study and the Cochrane meta-analysis suggested that there is some benefit, but then they did not include the neoadjuvant CTRT. However, if you looked at the EORTC 22921 data and the DUSH trial data, did not show any benefit in adjuvant chemotherapy. However, if you look at the Adore trial, in which the patient had almost YP stage 2 or YP stage 3, there was some evidence of having a DFS benefit, but still there was no overall survival benefit. So most guidelines up till recently, they advise that you do chemotherapy after CRT, but if you ask me, is there a strong phase 3 data, we all will say that there is no strong phase 3 data to it. So what is the evidence of TNT here? So we all have understood what is the TNT sequence. I myself am in favor of starting with the RT, consolidating with the chemotherapy, and then moving on to surgery. We all understood that you need time after the radiation for the radiation to act. The more time you give, the more the PCRs you achieve. With this basic aim, this is the sequence of TNT, and this has been almost proven by the OPRA trial that this is the way to go about it. We have a number of trials. All of these trials are there in the, multiple trials have been done, and all of them are there in these sequences. So obviously we have read through the Rapido trial. We have gone through it. We know the evidence of it. There is a short course 5x5 followed by 6 or 9 cycles of capox/FOLFOX. However, almost 95% did receive capox, and that was the experimental arm, and then there is a standard arm in which you do a long course CTRT followed by TME, and then followed by adjuvant 12 cycles of FOLFOX. So what you saw was the distant metastasis rate was 20% in the experimental arm versus 26.8% in the standard arm. Mind you, if you look back at the Adore trial, the standard arm in the Adore trial almost had the same distant metastasis rate. So it goes to say that I am trying to improve upon what was there in the Adore trial. So if you give the same therapy in the adjuvant setting, you will probably not have this good a benefit. The disease-related treatment failure rates are also better in the experimental arm. The locoregional failure rate, and now most of my, or possibly my colleague will get back to me in saying that, local regional failure rates were higher. But then please understand, the basic aim of this trial was to reduce down the distant metastasis. And we all have now understood and we have learned from the Rapido trial that there is some bit of T4 disease which doesn't respond to radiation. You, as a matter of fact, should be doing a radiation in between and seeing if there has not responded, and you should be taking them for a surgery sooner. So this is what we have learned out of the Rapido trial. And possibly the reasons that the local regional failure rates were marginally high in the experimental. So coming back to the Rapido trial, comparing the outcomes with the same chemotherapy given in the adjuvant setting, the rates were not that as good. The adjuvant chemotherapy did not benefit. It was the neoadjuvant which rather did the benefit, and the possible reason was there was a better compliance in the pre-op period. There were less chemotherapy cycles were there, so hence the compliance were also better, and there was an early control of the micrometastasis. And now once we are doing more and more immunotherapy, we also understand the meaning of tumor microenvironment, which is important for me as I grow. We understood the PRODIGE study also. I will not go through the trial design data. Again, the DFS rates were significantly better in the TNT arm as compared to the standard arm, and the PCR rates are also significantly better. Again, it's a stellar trial again. So let's skip the trials and move on to the part where, so this is where we are. There is enough data to suggest that the neoadjuvant short course radiotherapy, that is 5x5 plus chemotherapy versus concurrent CRT, there is enough data to suggest a better PCR rates. There is equal loco-regional relapse rate. There is a better disease-free survival and somewhat inclination towards a better overall survival. Now coming to the overall survival, which possibly is one part which the TNT has not been able to prove. So please understand, there is no randomized controlled trial or meta-analysis which have said till now that adjuvant chemotherapy can improve overall survival. I have tried, we have tried, and we have failed. So if you are harping about the overall survival, then we should not be doing chemotherapy at all. So the debate should be doing chemotherapy versus not doing chemotherapy. However, if you are choosing to do chemotherapy, the way to go is TNT. You can't say that the TNT is not the way to go in that. Coming to the nature of surgery and the surgical outcomes, we all have senior surgeons here. We all understand that the surgery is the paramount. When it comes to the local control rates, 60% of the local controls are still by the surgery. And the R0 rates are same, whether you do the TNT or you do the adjuvant. Yes, I would like to bring down my sphincter preservation. It will happen, it has not happened as yet. From a surgeon's perspective, so for better local control, radiation, so once you start with the radiation, consolidation chemotherapy provides you a better local control. If you have a heavy nodal burden disease, if you have a disease which is T4, you may have a discussion with the radiation oncologist and think about having a long course RT. Yes, you may have some bit of apprehension about short course RT still there, but then it is still the long course RT followed by chemo and then followed by surgery. However, if you have a T3AB or T3CD disease, a short course 5x5 followed by chemotherapy followed by surgery is the way to go. So there is a problem with short course RT beyond 10 weeks. It causes a lot of pelvic fibrosis. There's a lot of edema. So when it comes to the upper and the mid rectums, we are safe. I think it's the lower rectum which is the problem. The space is less and hence the surgery becomes a bit difficult. So if you have a low rectal tumor which is bulky, I may still consider that may choose to go for a long course RT and then followed by surgery sooner. But for something which is upper and mid, we are all, I think all our surgeons are well versed how to take out a pelvic fibrous tumor from there. So patient quality of life, none of the trials which I've been talking about have reported their quality of life outcomes. The duration of looking at the data which we have, duration of the entire treatment is considerably short in TNT, is 24 weeks. And rather, if you give a long course RT and follow it up by surgery and then by chemotherapy, it is almost 1.5 times longer. The duration of stoma to reversal, it's 4 weeks for TNT and almost 16 weeks for standard. Patients are proportion taking the chemotherapy. So almost 90% of the patients in the TNT end up taking chemotherapy, which is almost around 50 to 60% in the standard arm. Adverse effects, yes, they are numerically higher in the TNT. but still there were no increased post-operative morbidity. The number of patients completing the treatment are almost the same. So I think we have gone through the PRODIGE 23 and Rapido. Let's just come to the last slide. So local recurrences are lesser or equal with TNT. The distant recurrences are lessened with TNT. Disease-free survival is better with TNT. The PCRs are better, almost double with the TNT. Overall survival, the data is still immature. However, there is no data at all in the adjuvant setting. The nature of the surgery and surgical outcomes are same with both. The quality of life is better with TNT. And hence the reason in the last 2 years, all the major guidelines, they have established TNT is the standard procedure in the rectal cancer, be it be the T3 with CRM involvement, without CRM involvement, or the ugly ones, which is a T3 with CRM involvement or T4 disease. That is my time. Thank you.
Thank you, Bhuvan.
Good afternoon, everyone. So I have had the advantage of the entire auditorium speaking on this topic, and then I have to speak on it. So that gives me some kind of advantage. And I wish I was privy to Dr. Reena's slides before the debate, but let's see how it goes. And I think it's not a pointless debate. It's still worth looking into it. And the major parts of this debate are: 1, TNT for all; 2, I don't think the mid-rectal tumors is as important as all rectal tumors. So that's the basis from where we will go. So one thing we should be clear is the definition of TNT means I'm giving all my treatment before surgery. In all the major trials, this is not so. There is some degree of adjuvant given after surgery also. So I think the correct term is near TNT. But that's semantics, and we shall agree that TNT and near TNT are synonymous. The points to ponder, and this is more philosophy backed by science, is that, with TME, local regional recurrences are very low. The worry is distant metastasis, and this has been said ad nauseum by the speakers before me. Options for salvage are increasing in colorectal cancers. Wait and watch is something that patients are coming to us with. There is more and more data. And in rectal cancers at least, QOL is predominantly hampered because you have a stoma because of APR, or the Lars syndrome, which is much more than we see or comprehend. We know the benefits of TNT, or at least the purported benefits of TNT. There's increased PAT-CR, you're hitting micrometastasis earlier, you're reversing the stoma earlier, there is decreased toxicity rates, and there is, chances of organ preservation. Some of this is true, the rest is not borne out by data yet. So with those purported benefits, what you should have is an improvement in survival, and that is overall survival, because this is a potentially curative setting. I'm not going to be happy with DFS. 1, 2, and or improve QOL. That is important across spectra. Again, this is a variation of what's been already presented. The standard is NACTRT surgery, and you have other options for TNT. I'll concentrate on the 3 trials highlighted in red, just important points. The POLISH trial was one of the earliest. The mid-rectal tumors is the only part where I'll refer to it. All of them had a good proportion of mid-rectal tumors, approximately 40 to 50%. Did it achieve an improvement in OS? No. The Rapido trial again had around 40% of tumors. OS? No. Prodigy improvement in OS? No. Now, one point which a lot of people refer to was the follow-up is not enough. You have a median follow-up of 4 to 7 years. You're not going to get more recurrences beyond that. Whatever recurrences have largely had to happen have happened in 4 to 6 years. And all of these trials have a median follow-up of close to 4 years. So these patterns are not going to change in terms of overall survival. The other thing is, I agree, and I think Dr. Reena had mentioned the Rapido. I think that's a good option. But if you're giving FOLFIRINOX as per Prodigy, 4 times the number of patients had grade 4 adverse events. You are not going to be able to give it to all your patients, irrespective of location. So in a scenario where you're not having an unequivocal OS benefit, you're having some important survival benefits, increased toxicity. I'm not convinced. 1. 2, when it comes to patient-related outcomes and PROs and QOL, are you decreasing ileostomy rates? No. Are you increasing sphincter preservation? No. So what am I achieving? I'm not improving OS, I'm not improving QOL, I'm not improving PRO. So why should we give it in all patients? This is just a reflection again of the same slides shown earlier. So that's reiterating the same points, that OS is not there, QOL is not improved, should not give it to all. The other thing is, I think wait and watch is an important concept in today's era, and a lot of patients are coming to us with it, and it is not only for lower rectal tumors. It should be even considered for any tumor in a patient who's having a complete response. Now we know that anywhere between 10 to 25% of patients are having a pathological CR, they can be spared a surgery, and the more you look at these patients when they follow up longer, a lot of them have Lars syndrome. We should not underestimate that. So if a patient can not have surgery, that's a very good option. Now the argument that is often forwarded is that if I'm intensifying treatment, and intensifying treatment I largely mean chemotherapy, you are pushing more patients towards organ preservation, wait and watch, right? So these are two of the largest data sets with the wait and watch approach. The point I want to make here is, when a patient is put on a wait and watch program, the problem is not distant metastasis as much as local regrowth. So a lot of what Dr. Reena said in terms of intensifying radiation makes sense. You're increasing local control. Distant metastasis is only 6 to 8%. Now this is one database, this is another one, and both have a fair number of patients. One of them had 1,000 plus, one of them had 700. The problem is local regrowth to the tune of around 20 to 25%. Intensifying that, yes, possibly makes sense. Intensifying chemo alone, plus minus iffy is what I think. So, in conclusion, I think in the era of TNT, the fact that you're pushing more patients towards TNT, towards a wait and watch with more chemotherapy does not make sense, because at least 20% of these patients don't need more chemo. They can be observed without chemo and they will continue to be in remission for 2 to 3 years. You're over-treating these patients. And if you're giving them regimens like FOLFIRINOX, you're exposing them to treatment-related toxicity, which is not insignificant. So, in conclusion, this is just what I was saying, that I don't think TNT is a valid option for all patients. For some patients, yes. And Viraj had predated me on that. You can consider it in some patients, but you don't have OS data. I think you may not have OS data also in the long term. And in the era of wait and watch, giving everyone chemotherapy does not make sense, because a lot of patients are going to be over-treated. And with that, I'd like to thank you for your kind attention.
Thank you, Anand. Bhuvan?
Once they have received chemotherapy, the response, the good response which you have gotten has the chemotherapy has also contributed in that response. So when you say only wait and watch, the chemotherapy has already been a part of it.
Oh yeah. So I'll address the second point first. The two data sets I showed are only post-chemo radiation, and there the CR rates were 20 to 25%. No chemotherapy. I agree with Oprah. They had an improvement in CR rates, right? But no long-term data. The 20 to 25% is post-CTRT only. No intensification. And when we keep saying that there is no benefit of adjuvant, there are two contrasting meta-analyses published at exactly the same month. One showed a benefit, one did not show. 3. A majority of them used bolus 5FU. The ADORE, even though there was no comparator arm of observation, clearly showed a 73% DFS with FOLFOX. You are not going to get 73% DFS with observation alone. So the data for lack of adjuvant is all old, bolus, outdated. adjuvant chemotherapy likely has a benefit. We don't have great prospective comparative data for it, but the ADOR is a good enough base for us to say that it does help.
So just a small point. So the meta-analysis which you're talking about, they had a very varied population. People had received neoadjuvant CTRT, some had not received CTRT. So the evidence of using an adjuvant setting in which you have given a radiation is always doubtful. If you ask me if there is a good phase 3 data, is a category 1 recommendation to use a adjuvant chemotherapy which is not there. So again, the entire thing is decide as an institutional protocol whether you're going to give chemotherapy or not. If you're not going to give chemotherapy, it is okay to do a standard arm. But if you are, my again point is, if you're going to do you're going to give adjuvant.
So that
TNT
is one point, but second is the relevant point, not for all, because that surgery for this fibrous pelvis is also an issue. Although you mentioned the mid rectum should not be an issue, but the surgeons may have a different perspective.
No, let's ask the surgeons.
Yeah, so he is going to give his.
Yeah, he is the chair. He gives the final one.
Viraj, I wanted to raise a question after this.
You want to raise a question? Or I can do that now? Yes, you can do that now.
So, Anand, you said for some. Who are those some? And that sum is backed by OS and PRO data, or it's a personal opinion for that sum?
We don't know who's the sum.
But you said for some.
No, I said not for all.
But
there's a
that means
difference
for some-
between saying not for all
That means for
and
some.
for some.
No.
So-
I'm not resisting your comment. I'm asking for my knowledge.
Okay.
Whom
So-
and the backup of that data for whom comes from where?
Okay. So I'll give two possible answers. There's some data now to say that those who have T4 cancers at the baseline, they have greater local regrowth as well as distant metastasis rate. So maybe NACTRT is not enough for them. You could consider a TNT. Two,
EMV.
yeah, EMBI also, correct. But I was just mentioning one. Yeah. Two, I think a lot of this debate is US and European centric. We published data 4 years back. The good, bad and ugly, 55% of our tumors are ugly tumors. This is again, referral bias is possible. 25% of our patients don't have CRM negativity at the end of NACTRT. So this debate itself goes. You probably need to give them some kind of induction. But so that's the answer to your question,
Those
sir.
are the sum. Okay.
Would the lateral pelvic lymph nodes be one of the thought processes, or that doesn't matter? I'm just asking.
Saklani says here, so as far as I know,
The lateral
there are
pelvic
two
nodes.
different thoughts here. If the lateral pelvic nodes respond or not respond, whether they are to be taken in the surgical specimen or not, I think that's where the question lies. I'm not sure whether they are de novo adverse prognostic factor. So-
Okay. Sir, can we have your comments?
Meanwhile, till you say this is about lateral pelvic lymph nodes. Rapido or Prodage, they have not addressed it separately, whether this subgroup is doing better or worse. Yeah, Ram.
So, who are the sum? All the people who have not been included in Rapido. Rapido is concentrated only on the high risk, that is T4, N2, EMVI, lateral pelvic nodes. These are the inclusion criteria for Rapido. We do see patients who do not fit into any of these. So these are the patients for whom probably TNT is not going to be of much use.
Yeah. So it was an excellent presentation by both the speakers, and now they have their own biases, and yes and no. I am also a surgeon, and I bring the third dimension also, even though I have to do the justice of giving comment on the presentations. Local recurrence, if we talk about, actually healed when he came out with TME. His local recurrence rate was just 4%, even without neoadjuvant chemoradiation. So local recurrence is definitely one of the functions of how surgery is being performed. Number two, after neoadjuvant chemoradiation, the local recurrence rate across many series, apart from Hild, who has pioneered TME, is about 6% only. So, winning an argument here about what you mentioned, I probably tried to show that by adding TNT, it increases the local control rate more than what it is.
No. So I said it is the same. It doesn't change from there.
Yeah. So there is no benefit here. Now, the most important is when wait and watch, lower third, where it is primarily decided that either AP resection has to be done or you are going to do ISR. So AP resection, wait and watch, and you want to expand your criteria of giving neoadjuvant chemotherapy. Say for example, poorly differentiated tumors or patient having a bulky nodal disease across the drainage area, including the lateral pelvic node. So these are the high risk group where you would be concerned about the distant failure, where one can think about it. But other than that, as the whole point of TNT, the chemotherapy that doublet or triplet that we are talking about, is to reduce improve the overall survival. And since that is not shown, we are not worried about the loco-regional control. So at this stage, probably we do not have real justification to recommend to any of the patients. I would say there are some disadvantages which is not properly addressed, which are surgeon's criteria, that the toxicity. Now in Rapido, 20% of the patient had severe diarrhea on this treatment. So these are going to push the surgery even further later, because you want your patient to improve from this. So that is one. Number two, as I was mentioning, as you go away from 12 weeks to 16 weeks to 24 weeks, the chances of the surgical complications would increase, which is also not mentioned really into any of these two studies which I have seen. So that is a genuine concern, and whenever we are looking at patients upper and mid rectum. And the third important point is that many times it is mentioned that the chemotherapy is not started, like in pancreatic resection and now in rectal resections also, that chemotherapy is not started before 8 weeks, 12 weeks. Honestly speaking, the things have changed in surgery also, that with minimally invasive surgery, sometime we would tell our medical oncologist that 2 weeks have passed and from our side patient is now ready for adjuvant treatment if you dare to do that. So it has quite changed. So delay in giving adjuvant chemotherapy has probably is overstated now, I would say. And lastly, what Viraj mentioned is no data or basis he would tell, but we have that middle ground that Folfox and radiation is what we give to our patients, particularly young patients where they can tolerate. Probably Viraj can say right now, so it's a time that you mentioned.
We have done now almost 25 cases, long course chemoradiation along with a doublet chemotherapy, and I give full 8 cycles, and that way I can give back his patient at 16 weeks so that there is no fibrosis for him. I get all my systemic therapy, radiation is done, there is no added proctitis, there are no leaks so far. 20 cases, not much data, but yeah, we're developing, and what I took it from is German AIO trial, which had a DFS advantage. So we are doing that type of TNT. It's a middle ground.
So it's a Folfox with long course, or a 5FU with long course?
Folfox. 2 weekly, Folfox. Long course, 25 radiation, 28 radiation. Day 1. PIC line, day 1, 4 months Folfox, 4 months surgery. No adjuvant. Amazing results. 1 out of 3 paths. Day 1. So 1 out of 3 paths here. 3 we did non-operative management also.
Yep.
One of them reluctantly, but we did 3 NOMs. But yeah, we are having good experience. So okay, let's move on to